I'm going to talk to you about depression as a brain disease. I was asked to talk about mental illness as a brain disease. I could have talked about schizophrenia. I could have talked about drug abuse. I could have talked about post-traumatic stress disorder. But I didn't have enough time to do that. And I thought I would pick one of the diseases that reside above the neck, depression, because it's so prevalent and it's related to suicide. And there are a couple of things in the news today that you might have noticed. One is the Department of Defense announced today that at the current time there is a suicide a day in the armed forces. This year we will lose more men to suicide in the armed forces than to combat in Afghanistan or Iraq. And just think about those numbers. The other point I'd like to make to you relates to stigma, something you're very well aware of, and just tell you a brief anecdote about something that happened to us yesterday. So we have a brand new class of psychiatric residents, medical school graduates that have decided to go into psychiatry, 13 green, enthusiastic, young medical school graduates, one from the University of Miami. And she checked off on the Florida Licensing Board of Medicine application, have you ever suffered from mental illness? She checked off yes, depression. Okay. She received a letter from the Florida Board of Medicine saying that they were not granting her a license, that she could not start July 1st, that she must appear before the board October 3rd for a personal hearing. This was after she sent letters from her psychiatrist, from her psychologist, from me, all saying that she was completely well. Now, mind you, if you had a brain tumor, this wouldn't have happened. And we can't even take care of our own house in medicine. And it's something that I'm getting some of our attorneys that may be willing to do this on a pro bono basis, but just think about it. We're disrupting this person's career. Her teammates aren't really happy because they have to take more call at Jackson in the emergency room. And I serve, for those of you in Miami-Dade, I serve as chief of psychiatry both at Jackson and at the University of Miami Hospital. And together we have 270 inpatient beds. So I see a great many of the denizens that end up in your courtroom. We see between 50 and 85 patients in the emergency room in psychiatry at Jackson every day. So we're busy, and a lot of them are, of course, Baker acted. So I'm going to try to educate you and entertain you, and I'm leaving enough time for questions. I was thinking, though, you know, being a judge, I've treated a lot of judges in my career. I've treated several federal judges. I've treated several local judges, none in this room, I might say. And one of the issues that happens to attorneys and judges and physicians is that we end up getting a bit full of ourselves at times. And that's why it's really helpful to be grounded by our family members, our friends, and our clients/patients. And Steve knows this story, but I was elected to the Institute of Medicine, which is the highest honor that can occur in medicine. There are only 55 neurologists and psychiatrists in it nationally. It's a big deal. I was in Washington, putting my tuxedo on in the hotel room, and I said to my wife, honey, in your wildest dreams, have you ever thought I'd be elected to the Institute of Medicine? And she said, you're not in my wildest dreams. Okay. It keeps you humble. The depression is a horrible disease. It's an extremely common disease. If you want to think about what depression is, think about the worst day you've ever felt, the worst day of your life, and think about feeling that way every day, but not knowing why. After the death of a loved one, perhaps, terrible tragedy, a terrible loss. Think about this. I thought Shakespeare said it pretty well about this, and recognized in the 1600s that depression is a brain disease. Pretty prescient. But think about what it's like to not be able to sleep, not be able to eat, not be able to enjoy pleasure of any kind, and minutes seem like hours. You can't read, you can't work. It's really a horrible, horrible illness. A lot of very famous people have suffered from it. Winston Churchill one of the most famous, who coined the term the black dog of depression. It's an awful illness, and for many patients it becomes chronic. One of the worst things about depression is, unlike other disorders of both medicine and psychiatry, it's thought of by the general public as the kind of thing that you just picked yourself up by your bootstraps. What's wrong with you? Why can't you just get up and do it? This has been a problem for millennia, and it permeates medicine as well. The stigma about psychiatry occurs outside of medicine and inside of medicine. Medical students tell me that surgeons will often say to them, oh, you're going into psychiatry? Well, you don't need to come into the operating room anymore. You decided not to be a doctor. Well, excuse me, we go to medical school. We are doctors. And we're treating the most difficult of all illnesses, the diseases of the brain. Now, the brain is the most complex of all organs. It has 100 billion cells, and they make 800 trillion connections. So unlike easy organs like the liver is like a really simple organ. You know what the liver's like. Whether you're eating it or looking at it under the microscope, it's homogeneous. It's all the same. Liver's liver. There's no one part of the brain that's like any other part. So we know, and I'm going to convince you today, that these are brain diseases. No one volunteers for mental illness. Okay, no one says, you know what, I wish I had schizophrenia. I want to have hallucinations today. No one volunteers to be a drug addict. Who in their right mind would say, hey, I'm going to give up life and be a heroin addict, that's going to be my job? No one does that. All these people were somebody's child. And then we see them when they're a mess. And what I'm going to try to convince you of is that these are real diseases. They just happen to afflict the organ above the neck. And although we're trying to get parity, as you know, we really don't have real parity. Certainly not in terms of payers, which is a really big issue. So what's depression? Well, you have to have the symptoms for 2 weeks or longer every day, and then you have to have 5 of 9 of these symptoms. And what that is you're feeling depressed, blue, down in the dumps every day, a decreased appetite, usually with weight loss. About 15% of patients have weight gain and increased appetite. Being slowed down, being fatigued, feeling worthless. I saw a patient yesterday who essentially said, I'm a wasted piece of protoplasm. I might as well kill myself. I'm a burden on my family. I'm a burden on society. And part of that has to do with the cognitive dysfunction that occurs in depression. The constant tape that goes through patients' minds. I'm a bad person. It's my fault that I'm not better. I'm a burden on everybody. Who would ever want to be with me? I'm better off dead. And I'll talk a lot about suicide. One of the cornerstones of depression is having trouble sleeping. So it's bad enough that you feel bad, but then on top of it, you can't sleep. So you have trouble falling asleep, you wake up during the night, and then you wake up early in the morning and you can't go back to sleep. So it's miserable, okay? And unfortunately, it's very common. Lifetime prevalence rates for depression are 11 to 13% for men and 21% for women lifetime. So a fifth of women in the United States will have a depressive episode in their life. In most studies, it's about twice as common in women than in men. There are certain other settings in which it's even more common, nursing homes and patients in the hospital with other disorders. So this was a very famous study that was done, a collaboration between the Harvard School of Public Health, the World Health Organization, and the World Bank. And what they found was that in 2000, the major causes of disability are shown here, with depression being fourth most common. In 2020, it will be second, and in 2030, it'll be first worldwide. The other top 10 are all mental illnesses: alcohol and drug abuse, schizophrenia, manic depressive illness or bipolar disorder. It's really quite remarkable. If you look at leading causes of disease burden for women in both developing countries in purple And in developed countries in green, it's not even close. Even by 1990, in this age group, depression was by far the leading cause of disability. So why are women more vulnerable than men? One of the major reasons is the phenomenon of postpartum depression. Women who become depressed after childbirth. This occasionally, unfortunately, disrupts your lives because women who suffer from postpartum depression, and in particular bipolar disorder postpartum, are prone to not only be depressed but to be psychotic. And when they're psychotic, they end up engaging in activities that get you involved. So the famous case in Texas of the woman who killed her children, the woman in North Carolina or South Carolina who drove her children into the lake. I was consulted on both those cases and decided that I didn't want to be in the media. Both of them suffered from postpartum depression. But the danger of postpartum depression is not just those dramatic tragedies. And incidentally, women like that have a 2% rate of suicide and a 4% rate of infanticide. So this is not a trivial, statistically, an anomaly. What's the problem with postpartum depression is that women give birth. They are now in the most critical phase in which they need to bond with their children. And we know that if a child doesn't get the bonding they need in the first few months of life, there's hell to pay later. This is the most important relationship that you will establish in your life, is your relationship with your mother in the first few years of life. If you don't make that bond, you're going to have trouble with future relationships, particularly if you also have some genetic bad luck, and I'll get to that in a little bit. But this is a critical issue, and it's terribly underdiagnosed, because who do women see after childbirth? Obstetricians. What are obstetricians interested in after childbirth? Episiotomy, breastfeeding, this focus on the child's health, and obstetricians, bless them, are gynecologists who are really surgeons. Very few of them ask the questions about how are you feeling. Almost all women after childbirth have a bit of the baby blues. That's normal. Almost every woman has that. This is different. The baby blues last for a few days. The in-laws leave, and then suddenly the baby's keeping you up at night, and it's not easy. I'm talking about honest-to-God, hardcore anhedonia, inability to experience pleasure, in which women say to me, I don't even know what this creature is. I feel no attachment whatsoever. That's the harbinger of a disaster, and we really need to be better at it. So it occurs most commonly in single adolescent women after childbirth who are terribly alone, don't have any social support. It's a problem. A completely understudied area is depression after miscarriage. This is a terribly difficult issue, because the problem with this issue is that there's very little knowledge about this, and there's a tremendous amount of pressure on families who want to have children and are unable to, and they go to fertility clinics, and there's a tremendous amount of self-blame and expectation from families about this. And so, we see this a great deal, and there has been, in the fertility world, the notion that you should never treat women with antidepressants because it may mess up the fertility process. There's actually good data that if you're depressed, you're less likely to conceive, and you really need to be treated. When I was in training, before my hair was gray and I was young and I was in Chapel Hill, I was told that there was no such thing as depression in children. I thought, wow, that's a really cool thing. But it turned out not to be true. Depression does occur in children. We used to have a category in psychiatry called accident-prone children. That turns out to be children that try to kill themselves at age 3 and 4 years old, who jump out of tall buildings, throw themselves downstairs because they're depressed. So it's not very common, but it does happen. And it's much more common in adolescents than in young children, but it does occur. if you see a child who is not responsive to receiving a gift, there's only two possible diagnoses. They are either victims of child abuse that has not yet been disclosed, or they're seriously depressed, usually coming from families that are genetically loaded with depression. Adolescence is a little tougher because, as those of you who have adolescents know, it in and of itself is a mood disorder. I mean, you know what adolescents are like. I mean, I have 4 children, and fortunately, the youngest is at Chapel Hill, is a junior, but we've gotten through that stage. But you know what it's like. So it's really hard to diagnose depression in adolescence because there's the normal ups and downs, and of course you worry about alcohol and substance abuse. Depression in the elderly is a big problem, and I see it a lot in men in Florida. So what I see happen, I'll tell you a little tragic story, is a extremely wealthy man and his wife who made their fortune in New York City on Wall Street, moved down to Broward County, and his wife did great. She made friends. They had the book club, and they were playing all sorts of things that they do, and she was having a great time. And the husband was doing terrible, and he had trouble making friends. His golf game wasn't what it used to be. He tried to play tennis, but he didn't feel like it was good enough, and so he became more and more and more depressed. He went to his family doctor, and his family doctor said, the reason you're feeling depressed is you're getting older. What you need is some Viagra. It'll pick up your mood, so to speak. So he gives him a prescription of Viagra. His wife wasn't exactly delighted about this. And so he went to a hotel you will all be familiar with on South Beach and went to the concierge, said, could you arrange something for me? And so I started seeing him, and as I saw him, he was depressed, but he also started being cognitively impaired. And I thought this guy must have, an early Alzheimer's process. So I brought him in and did a number of lab tests, and guess what? He was HIV positive. And so then I had to bring his wife in and tell his wife, guess what? We need to test you, and she was positive. Okay? So he was depressed. He had HIV/AIDS with infection in the brain. Just so that you know, Florida has the highest rate of sexually transmitted diseases in people over 60. Okay? So what happened? He was depressed. His judgment was awry. Being 68, he hadn't thought about safe sex because it wasn't an issue when he was married 30 years ago. And it's a mess. So depression really ruins your judgment. But it's very treatable because the HIV part is a little difficult. So the problem is partly because of access to care and partly because of stigma, the vast majority of patients with depression don't get treated. The two major forms of treatment are antidepressant medications and psychotherapy, and I'll tell you about that. But in general, patients don't get treated, and there's major issues related to insurance coverage of depression and how mental health disorders are covered. You all know that. So, you can have great insurance and then mental health is carved out to some other company like United. I'm not necessarily saying any of these plans are bad, but the coverage that's provided is de minimis. And if you particularly have a chronic illness, like schizophrenia, bipolar disorder, etc., the amount of contact you could have with mental health is limited. We'll see what happens with the Supreme Court ruling because it's supposed to take away pre-existing conditions. But of course it doesn't say what the nature of the care is that's going to be provided. So to tell you a little bit about mood disorders, here are all of you. I'm going to just assume that you're all normal. I know that's a stretch, but let's just assume it. And you regulate around the mean of your mood. You get happy when good things happen, like when the Heat won. That was really cool, really cool. I really loved it with all friends in New York. They hated it, And when things go badly, we get sad. But we regulate around a certain mean. Here are people with depression. Okay, they are okay some of the time, but they plunge into these depths of despair in which the world is just totally black, and nothing feels good. And I'm not going to talk about this much today, but this is a lot of what you see in the courtroom. This is manic depressive illness, bipolar disorder, in which people go from being horribly depressed to pathologically excited and manic. And I saw a lawyer from Alabama last week who had a horrendous manic episode, and a really just awful manic episode. And during this period, he felt his children were not his children, and he left his law practice precipitously because he felt that his partners were plotting against him. And you know, when people are manic and ill, they engage in substance use, and so they oftentimes they get into big trouble with the law, and then of course you see them. Here's the bane of my existence, okay? This is a bad suicide attempt. This is a guy who walked into the emergency room at Mass General Hospital, said he had a headache. That's all he said. And it turned out that what he had done is take a Black & Decker drill, electric nail driver, and put it on his forehead. He had a little Band-Aid right over his head. It said he had a headache. And there it is. And this guy actually survived. But this is, unfortunately, an all too common problem, and I'm going to talk to you quite a bit about suicide over the next few minutes. The suicide rate in the United States is now higher than this. It's about 12.1 per 100,000. Now, what you might be surprised about is there will be this year more than 40,000 suicides in the United States. There are about 20,000 homicides, maybe less. So think about the news, think about the media. That probably would surprise you. How many AIDS deaths do you think there are in the United States in this past year? Just take a guess.
10,000.
11,000. Right. Good. Go to the head of the class. So think about it. 40,000 suicides a year in the United States. And it's going to jump from 10 to probably 8 this year for lots of different reasons. Florida was number 15 in 2007. It looks like we're going to go up. Just waiting to get the 2009 numbers. We were 14 in 2008. Takes a while to get the numbers, but we're up there. The states with the highest suicide rates are Montana, Nevada, Alaska. They largely relate to states where there are great distances in terms of availability of mental health services. Alaska, one of the highest. In the world, this is an unbelievable trivia question. What country do you think has the highest suicide rate in the world? No one is going to get this. Hungary. Hungary's suicide rate is almost 30 per 100,000. Probably a genetic issue. And the preferred method of suicide in Hungary is jumping in a well. It is a particularly bad way to commit suicide. Japan has twice the suicide rate of the United States. Iceland, the Scandinavian countries, because of alcohol abuse, very high. The only country in which women commit suicide more than men is China. In every country in the world, men have by far a higher suicide rate. Women attempt suicide more, but they're very fortunately terrible at it. Okay, because they overdose on 6 Tylenol, whereas men use guns and knives. But in China, women commit suicide more often. They're deadly good at it. They use pesticides as the number one. And last year, 250,000 women committed suicide in China. Part of the problem is that depression isn't recognized in China as a real illness. Schizophrenia is, but depression isn't. So in spite of all of our efforts, look how badly we've done. We knocked suicide down to the point where it was like number 14 cause of death in the United States. and look at what's happened, and it's keep going up. And part of this has to do with poverty and stressors, and part of it has to do with the military, and part of it has to do with the lack of availability of care. So one of my particular interests, I'm on the board of the American Foundation of Suicide Prevention, and the president of the South Florida chapter, is college students. And we lose 1,100 college students a year in the United States to suicide, and it's the third leading cause of death in youth, and it's the fourth leading cause of death in adults 18 to 65. And I would be surprised if any of you did not know somebody who had committed suicide, and how surprised you were when that happened. More than 90% of patients who commit suicide have a bona fide psychiatric illness that's either undiagnosed, untreated, or undertreated. So it is totally preventable. Suicide is a preventable phenomenon. There are a huge number of factors. The way you should think about it is that there are a number of factors that push people towards that threshold of suicide, and then there are factors that push people away or protect them from suicide. Some are controllable and some aren't. In the 10 years I looked in Atlanta at the medical examiner's office, I could only find 4 cases of black women who committed suicide. African American women seem to be protected in some fashion genetically. So even in the face of adverse consequences, the suicide rate for African American women is phenomenally low. And that should be a clue to us. Caucasian men are at incredible risk, particularly as they age. And that's the biggest risk factor, as you'll see. I'm involved in a number of expert witness cases in which someone's committed suicide and then somebody's being sued. Either the hospital's being sued or the doctor's being sued. Was it preventable or not? And there are some potential signs and symptoms that we could talk about, but the bottom line is it's very hard to predict who's going to commit suicide and who isn't. If I put everybody in the hospital who said they were suicidal, I would fill up every bed in Miami-Dade and Broward. And so it's really hard, and obviously we worry about the legal side of these things. But what's very clear is if you have a genetic risk, and I'll talk about that in a minute, for mental illness, particularly for depression, and then you're stressed by losing your job, death of a loved one, a natural disaster, having an acute psychiatric episode, then you're much more likely to reach threshold for suicide. There are really 2 kinds of suicide. There's the sort of classic, well-thought-out suicide. You know, life is not worth living anymore. I'm a burden. I'm going to write my notes to my family. I'm going to make it appear that it's not a suicide so they can get the insurance benefits. It's well thought out. That's 2/3 of suicide. The other third is impulsive suicide, and it's really hell to try to prevent it. So these are patients who are sitting at 3 o'clock in the morning. They can't sleep. They're on their laptop, and they send me an email saying, you know, I really want to thank you for everything you've done, but I've decided to hang myself. And, you know, if I'm up at 3 o'clock in the morning and I get that and I call the police, and then I say to the patient, I saw you last week, and, you know, you're 21 years old, and we talked about, you know, that you have this bright future and you're having a sort of rough patch. I don't know, this wave came over me. I was feeling all right, and then suddenly I felt badly, and I just felt like life wasn't worth living. It's really hard to deal with. This is the family pedigree of the Hemingway family. I thought you'd find it of interest. So what you're looking at here is, here's the person you know the most, Ernest Hemingway. Ernest Hemingway was discharged from the Menninger Clinic in Topeka, Kansas, and 2 weeks later he put a shotgun in his mouth and killed himself. What a terrible loss that was. But you'll notice his mother committed suicide, and her brother committed suicide. And his grandfather had bipolar disorder. And then you know Margot, his daughter, committed suicide. I've talked to Mariel Hemingway several times about this. They were absolutely flabbergasted. They had absolutely no idea. Suicide, like depression, runs in families. There's a debate in our field as to whether suicide is like a separate biologically driven phenomenon that cuts across diagnostic boundaries. Whether you're depressed, bipolar, or schizophrenic, I haven't bought into that concept yet. Now, part of the problem with depression, and as it relates to suicide, is that it occurs with a number, often, of other disorders. And we'll add substance abuse here as well. But post-traumatic stress disorder you hear more and more about. And it's a tough problem. It occurs very commonly with depression. Virtually every patient with post-traumatic stress disorder has depression. We just got a big grant from the National Institute of Health to try to predict who's going to get post-traumatic stress disorder after a traumatic event. Because what's odd about post-traumatic stress disorder is in the face of the worst trauma imaginable, only 40% of the patients get post-traumatic stress disorder. The other 60% don't. And what we learned in 2011 was if you treat everybody, a lot of people that wouldn't have gotten post-traumatic stress disorder get it because you're pushing it in their face. So we not only don't have the resources to treat everybody, if you treat people and push it on them, they're not gonna do well. So we're trying to figure out in this study we're doing in Miami at the Ryder Trauma Center of the people who come in with trauma, rape, domestic violence, etc. What are those factors that will predict who gets post-traumatic stress disorder? And now we're trying to work with the Department of Defense with the issues related to PTSD and suicide. So let's talk about treating depression. Patients come in, they're symptomatic, and you treat them, and with a combination of, say, antidepressant medicine and psychotherapy, and they get better. And then what you want to do is keep them well. But what happens is they often relapse. And the reason they relapse is, one, they don't like taking medicine, or they run out of their medicine, or they don't have insurance and they can't afford their medicine. And then they end up having to come in the hospital, which costs all of us a lot of money, or they don't like it. Nobody likes to take medicine. I don't like to take medicine. So, it's just sort of a normal phenomenon, and they stop coming to therapy. So where the future of psychiatry lies is in this slide. It's the future of all of medicine. So the problem we have in mental health and in all of medicine is you all come to us when you don't feel good, when you are sick. And then we do a bunch of tests and we tell you what treatment you need. And it doesn't matter whether you have cancer, heart disease, cystic fibrosis, or diabetes. But this is not the right way to practice medicine. What we want to do is practice medicine up here. We really want to know, what are you vulnerable to? What is it that you have in your genome? What hand were you dealt that will let us know whether you're vulnerable for schizophrenia, bipolar disorder, depression, colon cancer, ovarian cancer, breast cancer, diabetes? That's what we want to know so we could prevent those diseases. And this is where the future of medicine is going to be, and that's where we're going to save money in healthcare. Because I want to treat people before they ever get sick. So what causes depression? Well, a third of the risk is genetic. A full third of it is genetic. And we don't pick our parents. All right, you got what you got. So if you have a loaded family history of depression, the chance of you escaping it is less than those who don't. 2/3 of it is environmental. So this is sort of the genetic scorecard, much of what we've learned from identical twin studies, and I just wanted you to be able to see this. There's some diseases that are strongly genetically influenced. And they're mostly psychiatric diseases. Most cancers are not genetically driven. Most cancers are environmental. If you don't drink a lot, and if you don't smoke cigarettes, and if you have a decent lifestyle, you can avoid most cancers. Okay? Lung cancer is a good example. But bipolar disorder, 2/3 of the risk is genetic. Schizophrenia, 50% is genetic, and depression is 35% or so. So the good news about that is a lot of geneticists have been drawn to psychiatry to try to find what the genes are that cause the risk. So this is the sort of problem I'm dealing with in my life that I'm going to share with you. What I want to know is, how do genes that we just have no input into what we get change cells in the brain that change circuits in the brain, that's an magnetic resonance image of the brain, that result in this vulnerability to these psychiatric illnesses? That's the question. So what do we know about risk factors for depression that could give us clues as to what's the nature of these brain diseases? Well, the two biggest factors of depression is, one, if you've had an episode of depression before, you're highly likely to have one again. It's a highly recurrent illness. You can go for years and not be depressed, and then something bad happens, and you can get depressed. Stress is the worst part of this for many patients. They could do really well, and then a life stressor occurs, and they get plunged into a depressive episode. Women, I told you, twice as likely to be depressed than men. And then this is the other big factor, is child abuse and neglect. So the major risk factors for depression, and I'll show you how serious it is. And I've spent 25 years studying this. So stress is really an important risk factor. And this gets into all sorts of ethical issues. If you have a loaded history of depression or anxiety, should you be in Afghanistan? More importantly, should you be the American Airlines pilot flying me back to Miami today? These are ethical issues in bioethics that we need to cope with. Should you be a judge? I don't know. On the other hand, we don't want to ever use genes as a way. We don't want to say, oh, you've got a bad gene, you can't do this. We certainly don't want to get into that business. So these are tough issues, but we know that this is what's called the prototype gene-environment interaction. Whether you're going to get any disease is largely a function of your genetic vulnerability and your environment. So what is wrong with the brain in depression? I'm just going to talk to you about a few systems in the brain, and sort of I want you to leave here thinking, yeah, depression is a brain disease. So here's the brain, looking at it, sideways, if you will. So here's here's your nose out here. This is the back of your head. This is the cerebellum, which is the part that controls the motor part. And here's your higher centers of the brain. And these areas here are involved in the biology of depression. Okay, and one of the systems that's involved is called serotonin. My youngest daughter's name is Sarah Francis. And when she was 5 years old, I was giving a talk like this. And on the way home, she was coloring in the car. And she said, Daddy, who's that little girl, Serotonin, you were talking about? And I thought, oh, she's going to be on an analyst's couch one day in conflict with a neurotransmitter. Okay, so here's serotonin. It's found in the midbrain, down in the most primitive part of the brain. And these cells project wildly and widely to all parts of the cortex, which is your thinking part of the brain, as well as to the emotional part of the brain. And there are millions and millions of these terminals that, when they are active, release serotonin into the synapse between the presynaptic terminal, as it's called, and the next cell. And drugs that treat depression in part act by blocking this protein so that serotonin can't get back up here. It stays out here to act on these receptors. And those are SSRIs like Prozac and Paxil and Zoloft and Lexapro that you've heard about. This is a study we did looking at the brain in which we measured the target of these antidepressants. And so this is a picture of the target right in the most primitive part of the brain here. And that's where antidepressants work. And what we showed was that depressed patients have a deficiency of this compared to normal volunteers. So this is the kind of study that in the end we might be able to use to help diagnose depression. It's very expensive, uses radioisotopes, but the point here is that depressed patients really are different than non-depressed patients in terms of the availability of this critical component of the serotonin system. So you're going to bear with me because this is one of the most exciting findings on all of psychiatry, and I'd like to share it with you to convince you about how important genetics and the environment is in precipitating mental illness. So that target I showed you actually occurs in different forms based on what gene you have for it. You know, all genes, I'll give you a 30-second primer about genetics. We have about 22,000 genes in the human genome, all of us, and 99% of them are the same. But 1% are different, and you know that because if they were all the same, we would all look alike and act alike and be alike, right? If we all had the same genes, we would be clones of each other, and we're not. And it turns out this 1% difference between all of us is partly because genes occur in different flavors, and their flavors are called SNPs. And so that target, that serotonin transporter target I showed you, is one of those genes that exhibits this phenomenon. It occurs in different forms. So this was a study done several years ago. It was the leading study for all of science for the whole year. And what it showed was the following. It looked at three groups of patients: those who had no child abuse, those who had probable child abuse, and those who had severe child abuse. And it looked at the likelihood of whether they got depressed or not. And what these guys found in London was that in the absence of child abuse, the rates of depression were no different regardless of which form of the gene you had. But look what happens in the face of severe child abuse. There are three different findings here. So this group, the people who had this gene, were completely protected from the depressogenic effects of child abuse. Completely protected. Whereas these people were completely vulnerable. 60% became depressed. So this is an example of how genes are the hand that you were dealt. Nobody picked what gene to have. And that gets into that ethical issue I asked you about. So these folks probably would be suited better to be in Afghanistan, if you will. They're resilient, and they're probably relatively impossible for them to be depressed. If you don't get depressed after repeated severe child abuse, your brain isn't capable of getting depressed. But if you're this group, maybe you ought not to go. Maybe you ought to be at a desk job. And we've now identified 6 or 7 other genes that are like this, and together they really conspire. So if you have 5 vulnerability genes, the chance of you escaping a psychiatric illness is pretty slim. And if you have 5 resilience genes, you could probably be, Superman. I want to leave plenty of time for questions. There are other neurotransmitters involved in depression. Dopamine is a neurotransmitter involved in both depression and drug abuse. And it's clearly, there's no question about it, it is the neurotransmitter involved in the ability to experience pleasure. Whether it's fun at a ball game, whether it's sexual pleasure, appetitive ingestion, dopamine is the neurotransmitter that mediates this. The sad thing is that over time, we lose our dopamine neurons. They degenerate as you get older. These are the cells that degenerate early in Parkinson's disease. So if you look at this imaging study, the solid line are the normal volunteers. So this is how many dopamine neurons you have when you're 18, and how many you have when you're 55. And you see this fall. This, incidentally, is why there are no, like, 60-year-old, tennis pros. Okay, this is why Federer's performance was so heartening the other day. I went to when I was in Atlanta, I was a Braves fan, and I went to the fantasy camp here in Orlando with the Braves. My wife got that for me for my birthday. And I was a pretty good baseball player. I couldn't hit a fastball. It was the damnedest thing. I could see it. I could see it, I couldn't get the bat around fast enough. I could still catch, but damn, I could not hit. It was really terrible. So look at the depressed patients. The dotted line, at every time point, they have even less dopamine than do the normal volunteers. And so dopamine is involved in depression. And now we have all these very highfalutin imaging techniques to demonstrate conclusively that depression is a brain disease. And we can actually do studies in which we take actors and ask them to be sad. And, actors are amazing. They'll start crying. It's the damnedest thing. They'll get so in the role, they'll start crying. And they show the same brain changes that we see in depressed patients. And that's led to identifying brain areas that are involved in depression. And I'll show you why that's so cool. I do want to mention a few things about treatment. There are good treatments for depression. We're pretty good at it. Different forms of psychotherapy and antidepressants. Now, I want to get back to I promise I'll leave time for questions, but I want to show you some of my own patients' dialogue with me. This was a program we set up for the University of Miami. We started it at Emory. These are students who anonymously are writing to us because we found out that if we do it anonymously, they're more likely to reach out to help. And I thought, just to show you how awful this disease is, here's a student that wrote to us. This may sound silly, but it's held me back from trying to talk to someone earlier. Are there any repercussions for coming in? This is the Student Mental Health Service. Last year, I overdosed on a bunch of pills and I cut up my body. My father flew down here to kind of help me out. He said it was probably a good thing I didn't go to the hospital because they would have had to report a suicide attempt or something, and it could get me kicked out of school. If I admit to that or talk about my trip, will I get in trouble? It's heartbreaking. I wouldn't mind meeting you. One thing is bothering me, though. My parents used to pay for my therapist back home, but if I tell them now I'm thinking of going back to therapy, they would get really worried about me and might want me to withdraw or something. But then I wouldn't be able to pay on my own if it's as expensive as seeing private psychiatrists were. What do you think? I had a really bad year, and it seems like I'm either super happy or super sad right now. I'm sitting here crying on my bed, and I couldn't even tell you why exactly. I think that I'm most stressed out about, which makes me contemplate whether I should even live anymore or not, is really stupid, and even I can recognize it's dumb. I feel like I'm so lost because I'm so undecided about my future that I lose sleep at night. My parents will not stop bugging me about a major or a career. That made me stop bugging my daughter. And I'm beginning to think that no matter what major or career I choose, I'll hate it. My friends would probably never guess I'm depressed. I try very hard to hide it, but in the end it makes me worse because I feel like I'm not being who I really am. I think the depression questionnaire was a godsend before I did something stupid. People looking at my life from the outside would see a very normal, happy childhood, and I have a great family and people who love me. So I almost feel guilty about being so sad. I don't have a real reason to be, I guess, but it's nice to get this out. I filled out your survey last semester. You emailed me multiple times. I thought I had a handle on things. My friend committed suicide last week, and I'm finding it really hard to even get out of bed. It's awful. Okay, so here's the conundrum I have. And you see people all the time in your courtrooms who are taking various medicines. Some are better, some aren't. Is it the right medicine or not? Where psychiatry is right now is we're desperately trying to get predictors of treatment response. to match the patient with the right medicines, whether it's antipsychotic medicines, mood stabilizers, or antidepressants. We want to be like infectious disease and cancer. If a woman comes to us with breast cancer, we know whether she's estrogen receptor positive or negative, and we know whether she needs tamoxifen. If you come in with a infection, we can do sensitivity testing and know what antibiotics she needs to be on. But when you come to see me, and I think I'm reasonably good at treating depression, I don't know what antidepressant you're going to need, and I don't know what kind of therapy you're going to need. I'm going to have to do trial and error. And the longer I wait, and it takes for you to get better, the more you are at risk for not getting better. Because the more chronically depressed you are, the worse things are going to go. So let me conclude with a little look to the future. So I want to show you 2 other points. First, something that you don't know. I would suspect most of you don't know. Depression worsens other disorders. It puts you at risk for 3 major classes of disorders. Heart disease. Depressed patients are at a greater risk for having a heart attack. It's equivalent to smoking 3 packs of cigarettes a day, or having elevated plasma lipids. Ironclad data. More than 100,000 patients have been studied. Depression changes your body because it's a systemic illness. Because depressed patients have increased inflammation, decreased bone density, they're more likely to form a clot, which is what a heart attack is. There's no doubt about it that depression markedly influences cardiac mortality. So we have some new treatments. Both of these treatments were approved by the FDA for refractory depression, but third-party payers, including Medicare, won't pay for them. This is the first time in the history of the United States that the FDA has approved a treatment that CMS, Medicare, refuses to pay for. So this treatment, if you have epilepsy, it's approved for epilepsy and refractory depression, they will pay the $35,000 if you're having uncontrolled seizures. But if you have uncontrolled depression, it is not approved by Medicare, and the other payers follow Medicare. The same with this. This is a new treatment. It's sometimes called electroconvulsive therapy light, or ECT light. It's called rapid or repetitive transcranial magnetic stimulation. It uses a big magnet. It was approved 2 years ago by the FDA. And again, CMS has denied coverage. You can negotiate with third-party payers occasionally to try to keep people out of the hospital. And then the latest treatment is based on the imaging studies I showed you. There's a treatment called deep brain stimulation. If you put electrodes, very thin electrodes, into the brain of patients, right into this area, and you could see this on this x-ray, very thin electrodes. There have been about 150 patients studied worldwide. We started this program in Atlanta. We're now doing it in Miami. We've been able to reverse depression in the most severely depressed patients, about 75% success. It's never going to be widespread, but it is an important phenomenon. So I'm going to stop here. You've been a fabulous audience. Thank you for inviting me. Be glad to take questions.